Curbsiders, we are back with the last recap of SHM, the third day. We have learned so much. My brain is feeling nearly fried, but not fried enough to where we can't deliver an update. So
one might say we're delirious.
Oh, wow. What a segue, Meredith Trubitt.
I know. I'm surprised I could come up with that right now. Yeah, so we have just kind of last day is sort of a half day. So we have just like a few talks that we went to update about. I'll start, I guess, on the segue of Delirium.
Yeah.
This talk was so good. It was given by Ethan Cumberland out of the University of Colorado. It was super engaging talk, and he actually kind of designed the whole talk around how historically we used to bloodlet patients and how that also helped their delirium because that would make them unconscious at times and so sedate them.
Oh.
And then use that kind of into his segue, talking a little bit about other medications and things that we use that actually really don't have any evidence either now. But we want them to because we all have stories of, the patient who is delirious at 2 a.m. on like haloperidol. That patient got the dose and does better throughout the night. And so, but really there's no good evidence for any of the medications that we use, and did a good job, I think, at explaining that there's no evidence for that. We shouldn't be using them and all of those things. But I think he did acknowledge that what sometimes you have to do from a practical standpoint, because safety becomes an issue, might end up being a different conversation. And that's really kind of outside the scope of like guidelines or studies or anything like that. And obviously what you have to do on a patient by patient basis is a decision you have to make with an N of one. Kind of going forward, which I appreciated. And then he also talked a little bit about the 3D CAM scoring system to determine if patients are delirious. And I think at some point I knew this, I just kind of forgot. He was like, this is, has a sensitivity of 95% and specificity of 94% for delirium, which is largely also the score is based off of the DSM criteria. So like makes sense that it like works that way.
For sure.
So I just thought that was interesting as well. And then one other study he talked about, which we'll include in the show notes, was of early mobility to improve delirium outcomes. And 30% of elderly patients have like initial orders for bed rest. So you're really not promoting like early mobilization. And then the other common one that we all do as hospitalists is ad lib.
I'll be honest, I probably at some point knew exactly what that meant, but.
Well, he told us it's at one's pleasure. And they actually did this study where they put GPS monitors on elderly patients who had that as their activity order to see how much they were up and about. And it was a total of like 43 minutes a day. So that meant that 97% of their time they were immobile. So not really like the order probably doesn't mean as much as maybe other low cost interventions that people could be doing. So I thought all of that was kind of interesting. And I know you went to like the geriatrics updates. I'm sure there's some overlap. Yeah,
there's a fair amount. I think always going back through the CAM stuff is helpful because especially when you're talking with residents and stuff and they're trying to figure out if somebody's like acutely sick versus delirious. Like I still remember like the first time I dealt with delirium as an intern on night float and was very terrified and then realized, oh, this is what delirium is. And yes, I need to be concerned, but I also don't need to think they're dying. So one of the things that was a big take home from Dr. Sarah Bradley's talk out of Northwestern for geriatrics update is that the Beers criteria got some updates in 2022. Most of the updates are really just like having stronger recommendations than they previously had and stronger language. For example, using caution in rivaroxaban in patients over other DOACs for long-term treatment because it's got a higher bleeding risk. Avoid warfarin as initial therapy for VTE and non-valvular AFib, also a higher bleeding risk. And one of the language changes that's impressive is avoiding sulfonylureas as a whole, more class driven than it is. They used to just name specific ones, and now they're basically giving a class recommendation against using them. And then for limiting the use of long-term PPIs, which I feel came up in multiple talks this conference, they added language specifically in the rationale. So the biggest complications we worry about are pneumonia, C. diff, fractures, and renal impairment. Again, pneumonia creeps back up. And actually, this is going to come out before what I'm referring to, but it'll come up in one of the updates episodes that we do with Rahul Ganatra and Heather and I. So, but yeah, those are the biggest ones. And then I've found it interesting that the United States Preventive Task Force also put up some new recommendations in 2022 around things that I think elderly patients really will probably be a little irritated with, because they, really want patients to decrease supplementation intake. And I know how, a lot of elderly patients they love their supplements. So they recommended against beta carotene or vitamin E for the prevention of cardiovascular disease or cancer. And they said that there's insufficient evidence to support multivitamins in prevention of cancer and cardiovascular disease. So the grandmas are going to be upset. No more Centrum Silver.